in below ankle interventions, is there anything, we've talked about direct or indirect or angiographisomes. Some people call them woundosomes, which I like. I mean, does that play into your role of how aggressive you are on a pedal intervention, or do you just try to get what you can?
For me, it's usually like a de-escalation, or it's like a stepwise. If I can get direct flow to that wound, it's very important always to know where your wound is, put a marker, or you should know exactly where it is. And if whatever intervention I did, if I can see direct woundosome blush, I'm happy. If that's not going to be possible, then indirect, we know from the limited data we have from the retrospective data that that's better. And also, let's remember, something improved is better than nothing improved. So if you increase perfusion, and we're seeing this with DVA, it hopefully will induce some kind of improved perfusion. So if you can't get direct because it's not possible, and you reviewed it with you and whoever else you trust as because you always need a second opinion, we all do. And that's part of our humility. And you should have that. If you feel there's no way to get a direct, then get the indirect, because you're going to provide something improved, and then come back to the table when you redraw and see if there's something else to do. But to me, it's direct first, then indirect. And if all else, find something else, find DVA, find something else. And I think if you don't find something, there's nothing. But getting that satisfaction of seeing the wound blush, I always do a final AP picture, or whichever view shows me that wound area. I want to see either direct perfusers or micro perfusers or indirect, whatever I want to see. I want to see something increase that region to make me know I'm at a good endpoint. We're still learning the perfusion imaging and thermal imaging, all this stuff. I've played around with one of them to see, it looks at increased oxygenated hemoglobin that they can scan. Who knows? We don't know enough about that yet, but for me, you need some kind of endpoint. I don't know. What are your thoughts?
I agree. I mean, I agree with you. I was just thinking it's very important. When I started doing peripheral vascular disease, I would only get like a lateral foot view at the end, but I started getting more AP views, and I really encourage our listeners to get AP views, especially if you're doing below ankle, because you'll be surprised to see what's going where. That you don't see on the lateral. And again, if it's direct, indirect, it's just so satisfying and relieving when you see increased perfusion to the area of the wound. And we all know that increases your success.
We know this from being interventional radiology. We do this all the time, but you need more than one view to understand what's going on. So same way for me, a completion image has a lateral, and then it also has an AP with the cephalad angulation of the eye. So then the foot kind of comes down. You're looking at the top of the foot as if you're visually examining it. And that really changes your perspective, like you're saying. And just for trainees, you see what actually a pedal loop looks like. It doesn't look like a loop. It looks like a crisscross. It's crazy. Yeah. It's things that you learn by doing these things, and you have to educate to understand, are you optimizing everything?
Yeah, no, I mean, that once I started doing AP views, it was so much more information that I was losing on the lateral.